Hello, so my name's Ali. I'm the Deputy Director of the Mental Health Nurses Research Unit here at GMMH, and I'm very pleased to welcome with us today Professor Karen Wright, who's going to discuss a paper that she's written about the nursing therapeutic relationship. So yeah, Karen has worked as a nurse and a CBT therapist and has got a very long research history with particular interests in kind of personality disorder and eating disorder. Is that? Yeah. And she's here today to kind of discuss this paper that she's written. So anyway, I will hand you over to Karen and we shall get going. The presentation is going to be about 10 minutes, 10, 12 minutes, and then we're going to have a period afterwards for any questions that come up as we're going along. Okay, sorry, lost my train of thought there. Okay, I'll hand over to you, Karen.
Okay, lovely. Thank you very much. Yeah, so thanks, Sally. It's a real pleasure to be invited. I believe that I might be kickstarting a new iteration of this whole thing as well. So that feels like quite a responsibility, really. I hope I don't put you all off. that you enjoy it. So I could talk about this all day, so it might even need to be that after about 10 minutes somebody just tells me to shut up. But I've prepared a brief presentation that's based on the paper that Ali sent out to you all. So I'm going to share that with you and rattle through that. But I think perhaps the most important part in this very precious 30 minutes will probably be discussion, and I'm happy to answer any question or enter into discussion around it in whatever way is useful to you. So this is where we rely upon the technology working, isn't it? While I try to share my screen. Okay, so far so good. It's showing. Oh, of course, it started at the end, so let's just move it forward to the front.
There we go. Yeah.
This is your preview now. Doesn't want to move, does it? I think I might stop presenting and start uploading it again. Otherwise, it's going to take too. Okay. Does anybody know how you get it right back to the beginning without going through it all?
There should be an option at the top, say start slideshow if you're in PowerPoint.
Yeah, it says end slideshow, so I think I'll start it again. It doesn't seem to be just working as I want it to. Go back to the beginning.
So perhaps if you scroll up and just click on the left-hand side and click it onto the first screen, that might work.
Somebody's got their microphone on. They might want to switch it off as well. Let me just, there we go. Try again. Is that working? Can you see that now?
Yeah, it's not got into slideshow mode, but we can see the slides.
Yeah.
I think it's just deciding to do that. Okay, lovely. Great.
There we go. Yeah.
It's working. So
I was just going to say, it might be worth, if we're not speaking or presenting, switching our cameras off. That might sort of help things a little bit. Teams can be a bit glitchy sometimes. So
that's a good point. Yeah.
Yeah, so I'll turn my mic and camera off.
Yes. Lovely.
Okay, lovely. That's great. Okay, thank you very much. Okay, so I've not given it the same title as the paper, actually. I've just called it Authentic Connections because I think that the therapeutic relationship is very reliant upon authenticity, but also because the thing that has been incredibly important to me when I started my studies around the therapeutic relationship was the methodology that I used for my PhD, which was phenomenology. And of course, Heidegger talks about authenticity and about our being in the world. So authenticity to me has got a dual meaning definition, which is around the existential quality of that connection, as well as the genuineness that we think about when we think about being authentic with somebody else. So the things that I want to discuss in this very brief period of time are about making time to see, being your own instrument of care. That's use of self. It's a really well-known phenomena, of course, but never one to be taken for granted, I don't think. About creating healthy attachments. The word attachment often gets a bit of a negative press, and the mnemonic attach, which I made up to just put all of these principles together. And the reason I say make time to see is because I picked up my phone one day and it was on my notes, my reminders, and it just said make time to see. That's all I saw, and I thought, actually, you know what, I don't know why I wrote that, but that's a really good message. I should make time to see. I'm always rushing. But of course, when I read it a bit, I read the next bit, it said make time to see Caroline. Caroline is my daughter. I must have been feeling particularly guilty about not seeing her very much. But it just made me realise that actually that human connection includes not just hearing, not just being, but actually seeing the whole context and seeing the person. Because phenomenology and creating a relationship, it's all about being human. And that concept of common humanity is what makes the relationship personable, real, engaging, and unique. So the connection and the therapeutic relationship for me is all about being with another person rather than doing to or doing for. And when you look at it through a phenomenological lens, that is about seeing, valuing and experiencing the human condition, experiencing the other person, not just nursing them in the sort of traditional meaning of the word. And of course, we talk all the time about being one's own instrument because we talk about use of self. I remember being absolutely enthralled with Dawn Freshwater's work many years ago, and her writings around use of self, as well as Cheryl Fachuk's and other people's, you know, back as far as the 1980s. And I think we sometimes forget when we talk about using ourselves that doesn't have to be about our personal lives going into work. It's the way we are as an instrument of care in terms of how we conduct ourselves with the other person in a very genuine way, and still having the ability to switch on and off when you leave work and you go home, because using yourself so much at work is actually really exhausting. Actually, just doing something, just following a protocol and a rule book and a procedure, and doing what we do when we write in care plans and we say establish a therapeutic relationship, is okay theoretically, but actually if you really engage into person-centered care on a human level, it's actually really tiring, and you need to protect yourself, and you need to be sure that the focus is always on the other person, and that actually yourself, your life, and any element of self-disclosure is actually really well contained, so that you manage yourself as well as the space between yourself and the other person. Excuse me. And one of the mechanisms for that is reflexivity, and reflexivity is a word that tends to be used more in research than it ever is in practice. We tend to talk about reflection when we talk about practice. We tend to talk about reflecting on practice and reflecting in practice, and you know, the Benner and Rubel work from the 1980s has never really been superseded by anything that says anything fundamentally different. It's important to reflect on practice, but reflexivity, which is also fundamental to phenomenology, as you might guess, is a constant process of self-critique, self-appraisal, which is pivotal to practice and research. and the way we use ourselves in our endeavours, so that we're always keeping ourselves in check. And it's not just the practice that we're looking at, it's ourself. And as I say, that space around us that includes other people as well when we're in practice. Now, the reason I'm just going to mention attachment before I say anything else is because attachment has had a bit of a bad press in the past. We often talk about people being a little bit too attached, or there's an issue of attachment there, when actually what we mean is that somebody has got over involved, they've overshared, they've attributed a heightened sense of responsibility to themselves with regard to another person, probably one of your service users, and it's become a term that often is used with negative connotations. But I actually really like the word attachment when it's looked at through John Bowlby's eyes. You'll know that John Bowlby wrote a series of books. It's a while ago, but they've still got relevance, that's around attachment, separation, loss. And a really good and secure attachment is one that actually leads the person who you're attached with, maybe mothering or whatever, but the person that you're attached to, it leads them to independence. It's not supposed to be a permanent thing. It's supposed to be something that is transient, that is about developing that other person, helping them to be self-sufficient. Because of course, what we do when we admit a person to our services or into our care and treatment is that we engage with them, we connect with them, and right from day one, we set up some contracting or some discussion around, this is what your therapy plan will look like, and this will be when we hope that you will reach a point that attachment becomes separation. And that also needs to be healthy. And if we don't create a healthy sense of attachment, we'll also not be able to prepare for a safe or prepared ending for that relationship. So it's actually a dual purpose. So the attachment mnemonic, I'll come back to this after, is authentic, A, authentic, T, trustworthy, T, time maker, A, approachable, C, consistent, communicator, and H, honest. I'm just going to run through those sort of quickly, really, so as not to take up too much time. But obviously, we've talked a little bit about authentic and authenticity already. You know what that means. The words up on the screen there are sort of self-evident. Now, being trustworthy isn't just about the fact that we can trust somebody to do what we say they're going to do. It's about enabling the capacity for other people, the capacity in other people to trust you, and you have to prove yourself to do that, because they'll be watching you all the time. You'll have a little bit of time with them, but they'll be watching you a lot and seeing whether or not they think you're trustworthy. But also, we're not trustworthy if we don't give out good advice. What we say to people, how we handle information is it's just as important that is trustworthy than you know, our relationship and the way people believe they can trust us with information. It's the information that we give out also needs to be evidence-based and robust. Of course, being a time maker, well, if I could make more time, honestly, I would earn a fortune, wouldn't I? Don't you wish that you could just create and bottle time? Because time is the thing that we never seem to have enough of. But when I did my PhD study some years ago with women with anorexia, what I realised from their information, from the way they spoke to me, was that even a very small amount of time with somebody whose opinion and whose work they valued was considered to be equated with how much they were valued. So if a person that they admired and trusted spent time with them, it became a measure of their value. And that if we don't spend time with people, people feel unvalued. So actually using time as a precious commodity and using it equally with people is very, very important. So that's why time maker is in there. Not about creating time. I wish that was possible. And being approachable. Of course, we tend to think of being approachable as being sort of friendly. it's obviously a lot more than that. It's about being a good listener. If you're not approachable, then you can't really engage in co-production and partnership, because everything that we do is not just about our choices. It's all supposed to be collaborative and in partnership and co-produced. If we're not approachable, then that's never going to happen, is it? Because we have to be accessible and open to hearing other people's perspectives. So that's why approachable is in there. And consistent communication. Now, this is really important, and the reason that this is mentioned was not particularly to do with my work around therapeutic relationships and with people with eating disorders, but it was from some work that I've been doing for years around working with people with personality disorder, because being consistent, staying consistent, and being able to manage communication that is always reliable and safe and compassionate is very, very important. So not just about communicating things well, but communicating it consistently and treating people consistently. And being honest, of course, and being honest about the treatment options, possible outcomes. It links very closely, this, of course, with being trustworthy, because information that isn't honest is also not trustworthy. And so I've mentioned here again self-disclosure, but if we find ourselves being on the borderline of being honest from a very personal perspective, we need to be careful, because we really don't want to be in a point of being self-disclosing. We need to be at that point of disclosing evidence-based practice and information that is always centered around the person and the temporary nature of that relationship. So this is just a snapshot of what's in the paper, because you've all had the paper, but there's just a little bit of information along each side of one of those elements that relies upon the rest of the information in the paper and what we've just said there. So just really quickly to conclude, not all of our service users want to be with us. They don't all want to be cared for or treated. So being with and considering the presence of yourself and that other person in the same space is really, really important, because that's the key to creating a healthy attachment, irrespective of whether or not that person is happy to be there or happy to engage in the treatment or the treatment plan. Okay, so I'm going to stop sharing my screen now, I hope. And then open it up to a broader conversation, if that's all right.
That was great. Thank you very much. Lots for us to think about. If anyone wants to ask a question, if you want to pop your hand up, or if you want to type it in the chat and I can read it out. So yeah, if anyone's got anything that they'd like to kick off with. Oh, Helen.
Hi, thank you so
Hi.
much, Karen. That was really, yeah, really interesting. And I suppose it's just comments really. The first one is that this is, you put together so well, I think, what brought me into mental health nursing. This is the crux of why, you know, I wanted to be a mental health nurse years and years ago. But I think we find it hard to articulate really what we do sometimes, and so this is really helpful to bring us back to that. And the mnemonic I find really helpful, and I think particularly currently with the threats I think to this, which is we're facing, particularly my background is inpatient services, so with a transient workforce, with, you know, less time, that it's so important to be able to say why, what we do, what its importance is, and to be able to challenge back with some of the expectations. So just thank you very much, and from a mental health nurse, and I will share this widely. But really, really
thank you. Thank you. I think it's always been important to me, but actually somebody once said to me, well, everyone can care, anyone can care. You know, you're a registered nurse, you have to do more than care. And actually I really think that the elements of this includes the fact that we need when we create that connection, it needs to be around evidence-based practice and the sharing of that treatment plan that happens within that connection. So the enabling of what registered nurses do with the person, not just about the space that they occupy and about the caring and compassion. A relationship should be productive, shouldn't it? And yeah, thank you for your comments.
Yeah, that's great. Anyone else? I've got some. Oh, hang on. Yeah, Samantha. Yeah.
Hi, sorry, my internet's really unstable, so I'm just gonna keep the camera off if that's okay. It's really windy in Cornwall, so I was just, yes,
Crikey.
I know, God's country, what can we say? I was just really interested in, and I guess it really spoke to me. So we do a lot of interventions which are perceived to be interventions, various therapies, etc. And I think I've been a nurse for over 20 years, and I think sometimes the most important intervention we actually have as a nurse, which isn't perceived as an intervention, is actually that therapeutic relationship in itself. And I work with in CAMS, so really a lot of traumatized children, and actually just role modeling what a relationship where you're just occupying the same space over and over again, just repeatedly, not even always doing anything. Sometimes it's colouring, sometimes it's just creating that actually it's predictable, it's safe, it's containing, is the biggest intervention of all. And I think that that's really hard because it's not flashy and it's really hard to be a concept in itself, but we sort of we don't articulate that enough, maybe, within, to external colleagues, that actually that is a therapeutic intervention in itself. And if I could bottle it, and show, and I talk to nursing students and junior nurses about how important that actual connection is, then the other things will follow. I don't know if anybody else sort of feels the same.
No, I think you mentioned children though, didn't you? And often therapy with a child is play, and when you really create relationship when you play with somebody, don't you? The experience of play. But also, when I was doing a study with the women with eating disorders, I was looking at Borden's model of the Therapeutic Alliance, which is separated into 3 separate parts. It's the bond, the task, and the goal. And the women who were in there for treatment for their eating disorder never agreed with the task. The very last thing they wanted was refeeding, and they never agreed with the goal. The very last thing they wanted to do was to reach this goal, which was this weight, which was totally in conflict with their, with their perspective about how they wanted to be. The thing that could be achieved was the bond, and yet these women did recover in that situation, and they was largely attributed to the bond, even when the goal and the task could not be agreed upon. And that was just mind-blowing for me, really, that you can connect somebody better, really.
Completely. And especially in terms of eating disorders, it's the most dangerous, isn't it, in terms of mortality rates? And so in order to be able to do that, I've got a quick question. Sorry if I jump in. If anyone else has got one, please put your hand up or type. In terms of the self-disclosure element, how do you think, I mean, that's always something that has been, I guess it's more of a comment than a question. It's always been something that is very difficult to balance, especially if you've got someone who's inquisitive and you get on with, and they're asking you questions about your life. And it feels really difficult to manage that, I guess, sometimes, because you don't want to actively say, no, I'm not giving you that information. But it's about managing that interaction, isn't it, really, I guess, I bet.
Yeah, it's so tricky because you give away such a lot of yourself and you disclose such a lot of yourself that's not done directly or purposefully, because they've heard you talking in the office about what you're doing at the weekend or one thing and another, and people pick things up. But I think it's just this thing that the focus should always be on the other person, and as soon as you feel it coming onto you and the attention coming onto you, then you've displaced the aim of you being there. But my daughter gave me a perfect example of this. It's when she was at medical school, and he was the lecturer was teaching them about the Therapeutic Alliance, and he said, he pointed at my my little girl, she's not a little girl, Caroline, and said, listen, I'm a patient and I say to you, your hair is glorious, where do you get it done? Leading her into trying to say, oh, I get it done at such a place, and talking about herself. And she said, thank you very much, that's really kind of you to say so, but actually, is it because you're interested in your own hair? Is there something I can help you with? And she turned it round straight away. He said, oh, I didn't expect you to do that. I thought you'd just fall into the trap everybody does.
Cunning. I like that a lot. I'm going to take that one, although no one ever asked me about my hair. So I think Rob had your hand up, didn't you?
Yeah, I had a question, if that's okay. But yeah, thanks so much for the presentation, Karen. It's really interesting, and the paper's great as well. Actually, it's definitely one I'll be directing our mental health field students towards as well. You know, and teaching on the topic. I suppose my question was about potential difficulties in the therapeutic relationship, writing around things like alliance ruptures and that sort of thing. And I'm just wondering how developing the attach model, whether that's sort of changed the way you think about those sort of situations where there's kind of disagreements between service user and member of staff, and you know, sort of general tensions in the therapeutic relationship, and kind of how you're thinking about that at the moment.
Yeah, no, that's something I think that's something that used to be on my mind all the time when I was working in forensic practice. Actually, it was something that, and working with people with complex emotional needs, and because sometimes I thought I wasn't really meeting their greatest need for emotional comfort and emotional needs, and I didn't think it was possible, or that I just disagreed with what they wanted. And I think there's a very, very clear distinction with disagreement around treatment plan and therapy plan, and a sort of a falling out between two people. And we almost need to learn the skills of collaboration and negotiation when we work with people. I think our curriculum is focused on communication skills, achieving agreement about goals and things, but actually it's almost assumed that we know how to achieve agreement around goals, and the honesty around those goals, and the honesty about what actually is achievable. Because you can set a goal, and if the person thinks, oh well, that goal to me is that, it means walking away from here in 6 weeks time, but they're on a section of the Mental Health Act, or they're deemed dangerous or risky, that's never going to happen. And 6 weeks down the line it could all fall apart, because it's, well, you said that all this was about helping me to get out into the community. It's never going to happen. I don't trust you. You're not on my wavelength at all. And it could probably be traced right back to how that mutual goal was determined in the very first place, and what you set up as your capacity to help, and identified as their capacity for change. It's never something that just happens in the moment. Ruptures in the relationship or fractures in the relationship just never happen just like that. There's always something that can be traced back to it, but you probably can't even think about it at the time. And trying to repair a fractured relationship is really, really difficult. It's like you can repair a broken vase, but you can always see the crack. It's never the same as it was before. Although some people, I think, I'm trying to remember who it was, Irvin Yalom, I think, was, that said that actually a relationship is all about breaking and healing, and the strength of the relationship comes in the recurrent healing of that relationship because of constant renegotiation with the person. So maybe not to be too frightened of having little ruptures in the relationship if it enables a difference in opinion or perspective to be aired and openly discussed and worked through.
Amazing. And on that note, I think that's a really lovely way to end it, to be honest, because that's something we should all be working towards, isn't it? That kind of constant repair and reflection on all of our relationships that we have, because that's how you move forwards in life, isn't it?
Well, we do it all the time normally, don't we? But we don't even know that we're doing it. We wonder why we've fallen out with somebody, and we don't think about it. But you do think about it in practice, don't you? Because you take a responsibility for the relationship, and that's the crux, really, taking a responsibility for your part in that because
Yeah.
we always have a tendency to blame the service user when things go wrong, don't we? Which is we're just 50% in that, aren't we?
Yeah, no, that's amazing. Thank you so much for that. I've really enjoyed it
Well,
today.
it's been a pleasure. It's been a pleasure.